Hello, everyone, and welcome to our webinar on dysarthria secondary to stroke, traumatic brain injury, and more, when and how to use LSVT LOUD. We're delighted to have you join us this evening, or perhaps it's this morning, depending on where you're chiming in from. And this webinar is being brought to you by LSVT Global, where we pride ourselves in innovation in science and integrity in practice. The presenters for this evening include myself. I'm Cynthia Fox, my colleague Brianna Rogers, and Christy Jenks Schwably, but she unfortunately has no voice. So she has contributed content. We won't get to hear from Christy today. I'll be sharing a little bit of her information. She has so much wonderful content that we are going to try to do another webinar later this year that we can get her on and expound upon some of the information that I will just give you a brief highlight on as we go through today. So let me tell you just a little bit about us. We're all speech language pathologists. I have been with LSVT Global since 1994. Have done much of the treatment. I treated my first LSVT client post-stroke back in 1995. I currently serve as CEO and I'm one of the co-founders of LSVT Global. And I will do a little bit of introduction, but our main show this evening will be Brianna Rogers. She is the supervising speech language pathologist at Open Line Speech and Communication, which is a private practice located in New York City and Los Angeles, run by Dr. Jessica Galgano, who's also one of our LSVT LOUD faculty. And so Brianna has extensive experience working with adults who want to increase quality of life while dealing with neurodegenerative disease, are recovering from stroke, brain injury, or are working professionals looking to refine their skills. And Christy is Director of Speech Language Pathology and Director of Concussion Center at Mountain States Therapy in Denver, Colorado. Our full bios are in the slides and also in the handouts, so you can certainly learn a bit more about us, and you'll have those bios for your records if you need them for CEU tracking. All presenters have both financial and non-financial relationships with LSVT Global. Non-financial, including a preference for LSVT LOUD as a treatment technique. Financial, I am an employee of and receive lecture honorarium and have ownership interest in LSVT Global. Brianna and Christy are presenters and receive lecture honorarium. A few quick logistics. All of your microphones are muted. I think everyone is familiar with this process. So we'll keep it that way as we go through the presentation, but at the end, you'll be able to unmute and ask a question, or at any time you can type a question into that question panel. We'll either be able to answer it via the chat mechanism, or we'll save that to be able to answer at the end. There are handouts. You should be able to download those from your control bar. They were also sent to you in the pre-webinar email. If you did not get them either way, you can ask for them and we'll include them also in the post-webinar email. The handouts include the slides, but they also include a handout to the Speech Accessibility Project that we are helping to recruit voices of patients with Parkinson's disease to help improve communication of technology devices. So if you have patients who might be interested, please download that handout and feel free to share it widely. There'll be a survey at the end of the webinar. I'll give you just a bit more information on that in a moment. And please know that this webinar is being offered for ASHA CEUs. In order to receive that CE credit, you do need to watch the entire 1-hour presentation, either live or on demand. You'll need to complete the self-assessment survey. If you're viewing live, that will launch at the end of the webinar, and it will also be sent in a follow-up email. So if you don't see it at the end of the webinar, watch for that email that should come about 1 hour after the conclusion. On-demand viewing, there'll be a survey link that you can find below the webinar description in the on-demand section of your clinician account and in the YouTube webinar description below the video. These webinars are a course that runs through the end of 2023. So if you have the ASHA CE registry, we will report all of the CEUs at the beginning of 2024. Don't worry, you'll get the credit for attending them in 2023. And if you're watching this live, you'll get a certificate at the completion of the webinar. If you're watching on demand, you must complete the survey in order to receive that certificate. And it may take up to 1 to 2 weeks for that certificate to come. Okay, now that we've gone through logistics, let's talk about our learning objectives. We want to have you be able to state common communication impairments and how that affects individuals associated with stroke and TBI and other acquired brain injuries. To summarize the research investigating LSVT LOUD applied to clients post-stroke or TBI. Identify the decision-making process for determining if a client with dysarthria secondary to something other than Parkinson's is a good candidate, and list some special considerations and adaptations for utilizing LSVT LOUD with these clients. As we know, treatments for people with dysarthria secondary to neurological diagnoses are desperately needed. Up to 1 billion people globally are living with a neurological disorder. And we can see that stroke, for example, is one of the highest incidences of individuals with neurological disorders. And this is only expected to increase as the baby boomer population continues to age. The negative impact that those who suffer neurological conditions and communication disorders, that it has a very negative impact, and decreased loudness, decreased speech intelligibility, decreased naturalness of speech. Individuals encounter negative attitudes or discrimination secondary to the dysarthria they're experiencing, diminished engagement in communication. And certainly all of these individuals present us with complex challenges, and they're challenging to treat. And so that's where LSVT LOUD comes in. And for anyone out there who's new to LSVT LOUD, we have over 30 years from the initial development to where we are today. We've gone through the 5 phases of research, with phase 3 being establishing efficacy. And so it's a solid treatment. And so when we think about LSVT LOUD, we might think, why would we want to push that beyond Parkinson's, which was the initial population that it was studied for? Well, it's an established treatment approach, and LSVT LOUD can work to improve and restore communication. Also, as we move through those phases of research that we saw on the previous slide, actually phase 4 of research, once efficacy has been established of a treatment, is to apply that treatment to different populations. And that's a piece of the work that we'll be presenting here today. The key concepts of LSVT LOUD are that the target is voice, always healthy vocal loudness. The mode is intensive and high effort. Calibration addresses barriers to generalization of treatment effects outside of the room. And these key concepts are applicable for a range of neurological disorders and a variety of dysarthria types. If we start by just thinking about voice as a source, if we look at this chart here, we see on the far left the classic different types of dysarthria. In the next column, we see example populations that this dysarthrias occur in. Starting with the top, hypokinetic dysarthria is most common in people with Parkinson's. But now let's look at how the voice is affected across all of these different dysarthria types. And that's where LSVT LOUD can come into play. So the classic that we know, hypokinetic, we have reduced loudness, breathy, hoarse voice quality, mono loudness. So the rationale for LSVT LOUD is increasing that amplitude of output and improving voice quality. When we go to something like spastic dysarthria, the voice is also involved, but in a different way. It's strained and maybe strangled voice quality, sometimes, though, also breathy and reduced loudness. So, with LSVT loud, we're targeting healthy vocal loudness to improve voice quality and stability and control over voice. I'll just do one more. You've got this whole chart for your notes, but ataxic dysarthria. Here we have variations in loudness. So sometimes it's too loud, sometimes it's too soft, sometimes there's harsh vocal quality. So again, using the voice as a source and a point of entry of our treatment, establishing good respiratory laryngeal control, we can sometimes give individuals better control over their vocal loudness, improve vocal quality, and stabilize vocalization. So this is a good chart to turn to as you're thinking about why would LSVT loud apply to other different types of dysarthrias. What's exciting, however, is the voice also acts as a trigger. So we know that when we drive vocal effort, not only do we get those improvements in healthy vocal loudness and voice quality, but we can see trigger improvements in breath support, mouth opening, intonation, articulation, rate, and naturalness. So it becomes a very efficient way to improve communication. I'm gonna not show that video. You're gonna see really wonderful treatment videos, and so in the interest of time, I want to give Brianna those videos to see. But I'm going to move on to the mode of delivery. So the mode of delivery of LSVT loud is intensive and high effort. This is important for both healthy and disordered motor systems. And intensity and high effort is key to effecting behavioral changes that last over time. It's applicable for both adults and children, and it's also consistent with principles that drive activity-dependent neuroplasticity. The last key element in LSVT loud is calibration. In Parkinson disease, calibration is very specific in that it's addressing the sensory mismatch, problems with internal cueing, and subtle neuropsychological changes that can happen in people with Parkinson disease. So it's aimed at helping people with Parkinson's recognize what feels too loud to them is actually within normal limits, and also treating them in a way that takes into account the difficulties with cueing and the challenges sometimes with learning. When we look beyond Parkinson's, we can see that other neural conditions also sometimes have sensory components to their dysarthria. They need to learn a new vocal effort required for improved speech production. Sometimes we're dealing with significant social stigma that occurs as a result of the dysarthria and teaching them ways to be able to speak more confidently. And certainly we can also have cognitive challenges in terms of language deficits, difficulty with attention, memory, reasoning, and decision making. Our research includes single subject case study and small group designs, and there actually was recently a randomized controlled trial published in Multiple Sclerosis, and this is a sampling of the diagnoses outside of Parkinson disease that have been published with LSVT lab. So atypical Parkinson's, DBS, stroke, MS, ataxia, cerebral palsy, both in adults and children, Down syndrome, both in adults and children, autism spectrum disorder, healthy aging, and TBI. And there's a QR code to view those full references. So while we do not have the depth and breadth of data outside of Parkinson's that we have for Parkinson disease, we do have insights and studies that have looked at outcomes and also inform us for the case of when it may be applicable and when it may not. Now, the decision-making process is taught extensively in our training and certification courses, but from the overall point of view, we like to say LSVT loud is not for everyone. And even though we talk about it beyond Parkinson's and that it has wide-reaching applicability, we are not saying it works for everyone. It does not. But what it becomes outside of Parkinson's is another tool in your toolbox that you have, in particular for these challenging cases that come your way. How do you decide if LSVT loud is appropriate? You will go through a process, and I think Brianna will take you through some of the considerations as she walks you through a case study of thinking about what is the medical diagnosis, what are considerations for rehab, intensity, voice treatment. Are they stimulable for improving loudness? And what are our stimulability testing results? We oftentimes then do trial treatment and see after 1 week, how's it going and how are they responding? And then we use our clinical judgment to make those decisions about whether LSVT loud should be continued or perhaps discontinued. And of course, we work with the client and their support network through discussions and in the decision-making process. So with that overview, I'm now going to turn it over to Brianna, who's going to kind of put that information into life in a case study and her extensive experience using LSVT loud in individuals beyond Parkinson's disease. So Brianna, I will let you take it from here.
Perfect. Thank you, Cynthia. So for applying Parkinson's post-stroke, there are a lot of different considerations. And the beginning of the process will start out fairly similarly, where you'll start with the initial assessment. And then from there, see if your client or patient might be a candidate for LSVT loud. And so Cynthia, I'll have you move to the next slide and we'll go through some of that assessment process. So for assessing an individual post-stroke, there might be a lot of different factors that you have to consider. Are they currently inpatient? Have they transitioned to a rehabilitation center? Are they now outpatient and considering therapeutic options now that they're home and transitioning with their family? And within this, at our practice, we typically start with an initial phone call to see what the medical background is of the client, where their stroke occurred, and the impact and symptoms that they are experiencing. And then we use that to then determine what an assessment should look like, whether they should do an intensive week of assessment. We sometimes have individuals come in where they'll do 3 days of diagnostics, and then we'll have a day to analyze their results and then discuss with their family. Or if it's more limited, if you have an hour or 2 hours to work with that individual, what diagnostics can you look at for them with that time constraint? And so within an assessment post-stroke, you're still going to look at the holistic person. They might have cognitive communication challenges where aphasia or executive function are present. They might also have difficulty with motor planning. You might see apraxia or dysarthria. And then swallowing can also be a co-occurring condition where there's dysphagia. And so within the assessment process, you want to have a mix of your informal measures to see how they are functioning with standardized measures as well to look at all of those areas. And if you do have limited time, the family can be really helpful in the beginning so that you know which areas to key into for this person. Within the assessment, you also want to be looking for stimulability. So if the person is coming in post-stroke, their loudness is reduced, you're noticing that vocal quality is impacted, or if they are less verbal and having difficulty initiating that speech, then they might be a candidate for LSVT loud. And so you'll want to do stimulability testing to really key into that area. And within stimulability testing, you can do sustained phonation, see what their vocal quality is at baseline, and then give them those loudness cues to see how they respond. And if they are improving their duration, you see that increased breath support, or you also see that they are improving their overall vocal quality and loudness with those cues and models, then they might be someone that is stimulable for this treatment. The other area you can look at outside of the motor speech tasks is looking at it functionally within language. I will often do a language sample with clients and then give them cues to speak louder and see if they start to improve that clarity, or if their rate of speech improves, if that loudness goes up and then is that entry point for that overall clearer quality and intelligibility of speech. And so that can be something that is very helpful in seeing if they are a candidate for LSVT LOUD. If conversation and initiating speech is more challenging, the other area that you can look at for stimulability is looking at having them read either short phrases or words, or a full paragraph or longer reading sample. And then you can also have, if reading is impacted, you could give words or phrases where they try to imitate and copy, seeing what they are at baseline. And then if you give those loudness cues, how they respond when that is provided. And so as we go throughout this, we're going to talk about the assessment and treatment process. And I also am going to show you one client that I worked with that was a very interesting case with a lot of different factors for her treatment, but she ended up being an excellent candidate for LSVT LOUD. And so we can go ahead and go to the next slide. And for LSVT LOUD, the client that I was just starting to introduce was an excellent candidate, partially because of the spreading of effects for LSVT LOUD. Within this treatment, it can be so helpful that with just that one loudness cue, which particularly for individuals post-stroke, gives them one item to focus on. And that can help with any cognitive restraints, where they have that one cue of loudness that then can be this driving force for a whole spreading of effects. For the client that I mentioned, by increasing that loudness, she was able to take a deeper breath. Her posture improved. She had greater mobility and movements within her mouth and oral motor structures. She also had dysphagia, and we were working on swallowing goals as well. And so with that increased posture, there was better swallow safety. It's also possible too that she had better hyolaryngeal movement and better strength at base of tongue, so that it was a nice, easily coordinated swallow. So we are focusing on the direct impact on speech, but it can then have a spreading of effects to swallowing as well. And within that spread of effects, you'll have the physical spread of getting that nice loudness, but for individuals post-stroke, it can also be nice where it is starting to get them speaking again, and then that boosts the overall confidence. So if you are still working on aphasia or any cognitive communication deficits, by getting speaking, getting verbal again, and being understood by friends or family, it's very intrinsically rewarding, where then you are motivated and want to be speaking. And so for this individual, they were highly stimulable, and this spreading of effects was going to be really nice for their particular background. And so we can go ahead and go to the next slide. And so during that assessment process, whether you're doing an initial assessment for 1 or 2 hours, or you're doing a week where you're really doing a comprehensive assessment, you'll want to figure out for that individual what their priority of goals are. If they are presenting with aphasia or cognitive communication deficits, if they also have feeding and swallowing goals, if there's motor speech coordination goals and overall voice and vocal quality, all of that you want to consider. And you want to incorporate your own clinical expertise and considering what they were stimulable within sessions or within that assessment, what might help them most within their treatment. But then you also want to communicate directly with the client to see what's most important to them. It might be that getting and being verbal again is really a driving, motivating factor. And so in that situation, LSVT Loud might be a good starting point to really get speech going, and then you can work on the cognitive communication demands as they move up through the hierarchy of LSVT. You also want to consider the family. They'll also be deeply involved, oftentimes, with this population. And there can be a lot of frustration at home when they're trying to communicate if there are those communication breakdowns. And so, what is important to the family and also the client should be considered when you're setting those goals. And that will then help you figure out the timing of LSVT Loud. If they showed stimulability during the assessment, then you'll want to bring that in and might use LSVT Loud as a starting point. You also want to look and see for this program that you want to ensure that they are able to do the sessions for 4 weeks with those hour appointments. It's individual, and you want to map out your calendar for yourself and the client and family, considering vacations, holidays, medical appointments. A lot of times individuals post-stroke will have a lot of different appointments. They might be going to the neurologist for follow-up or cardiologist. They might be going to a neuro-ophthalmologist. They might also be doing OT and PT, or maybe they're considering LSVT big. And so the timing of the intensive will be important to ensure that they're able to make all of their sessions to have the best results and really keep the protocol intact. The other consideration as well is you'll want to remove any barriers for these sessions. So for setting, you might want to consider if they'll be coming into your office, if you want to do a mix of online sessions, and if they're a candidate for online sessions. I once worked with an individual that hearing was impacted and wasn't quite able to always have the hearing aids in. And so online was very challenging for a lot of different reasons, but audio was more difficult. But LSVT Loud is just as effective online as it is in person. And so if you can get that client set up, or if they need help from a family member or caregiver and get them set up, then online could be an option where they don't have to commute, they don't have to deal with a wheelchair and getting an accessible ride to and from the office. And so that can also be a way to remove a barrier. Or you might also want to consider doing home sessions as well. And so looking at that combination of setting and then the timing where you're sure that the client and family are really ready to commit will really help get those best results from the intensive. And part of ensuring that a client and family are ready to commit is making sure that they understand the principles. So going through that assessment, providing that education, and having it align with their goals will help with that commitment process. And so you're good, Cynthia, you can go to the next slide. So for this particular individual coming in, she had a left CVA. You're gonna see videos of her. When she came in for the initial assessment, her loudness was reduced, her speech was highly unintelligible, her vocal quality was hypophonic, and she had a rough and breathy vocal quality. She was unable to express her basic wants and needs. She was typically speaking in 1 to 2 word utterances, but they were unintelligible. During the first hour of assessment, I could only understand what she was attempting to say if we had shared context, if she was either copying me or reading off of something out loud. And this resulted in reduced engagement with her friends and her family. She was not participating in conversations. She had stopped her social activities. And she also was having difficulty with feeding. So when she was discharged from the hospital, she had food modifications, such as thickened liquids and a puree diet. And so they wanted to work on increasing communication again and also working on feeding. She also had other cognitive communication deficits and was bilingual, and it was impacting both languages. So that was going to be incorporated into her treatment plan. And we can go ahead and go to the next slide. And so during the assessment, she was highly stimulable for LSVT loud. She was responded well to the loudness cues, where when I modeled increased loudness for her, her phonation duration was extended and she was able to have that better breath support underneath that phonation. She also was more intelligible and had clearer articulation when she was speaking out loud. I had her copy a couple of phrases that I was saying, and then she read aloud as well, and her clarity of speech improved drastically. And so we decided that this would be a good entry point for her program where she would start with LSVT Loud. It also, because she had other considerations, was incorporated into an intensive program where we did 4 weeks of treatment. She did it daily, 5 days a week for 2 hours at a time. The first hour for the first 4 days was strictly LSVT Loud sessions. The second hour was feeding training and then also family education. And then on the fifth day, it was a combination of family education and more cognitive communication. But what was a nice crossover with LSVT Loud with those other exercises is when she was speaking or working on other tasks, we could also cue for loudness, which caused greater generalization of those skills. And so we're going to go to a couple videos for her, and I'll describe it. But this is just a quick overview of we wanted to really increase her speech clarity to drive that engagement and participation again, get her confidence up where she could be speaking in both English and Amharic. It was helpful that with LSVT Loud, we're working on those underlying motor speech principles. And so that could, in her situation, cause improvements in both English and Amharic. I was not bilingual in Amharic, and so I had to learn from her family different phrases and pronunciation, which got them involved in the therapy process and drove better outcomes as well. But she was able to see benefits in both languages. We also wanted to work on word retrieval and sentence generation and organization, working on her feeding goals as well. And with LSVT Loud, particularly when we got to the higher stages of hierarchy, you could work on word retrieval and sentence generation while still making sure that she's keeping and maintaining that loudness. And so we can go ahead and go to the first video.
I'm doing.
You're doing? Are you doing okay or are you good?
Oh, okay, good.
Good, exactly. You can say nice and loud, I'm good.
Yeah, I'm good.
Perfect. Excellent. That's what I like to hear. So, we're going to go back into our exercises. And I know it's been a little bit of a break since you've done these, but I'm going to show you a piece of paper. Hold on. Okay, here we go. And what we're going to do with these is the first thing, I'm going to share it so you can read along with me, is we're going to do our loud ahs.
Okay.
So we're going right back into our old habit. We're going to do the loud ahs, and we're going to do 15 of these. Exactly. Then, after that, we're going to do our high ahs.
Us.
Exactly. And we'll do 15 of those. And then we're going to do our low ahs.
No, us.
Yep, and we'll do 15. And then we're going to do our functional phrases.
Functional phrase, okay.
And then we'll have a conversation for a bit using our loud voice.
Okay.
All right, does that sound pretty good to you?
Say it again.
Does that sound good to you?
Yes.
Perfect. So for that first video, this would be a modification that someone post-stroke might benefit from. For her, I wanted to preview the exercises so she knew exactly what to expect as we went through the sessions. We would go through and for each one, we would check it off the list. This was able to ground her in the task, really increase the focus, and then it also increased that motivation as she went through. As she successfully accomplished each task, she was usually thrilled. And for her, auditory comprehension was reduced. So I wanted to make sure that we had a visual. And also her English was her second language. And so having the visual reading was actually stronger than listening to it verbally. And so having a multisensory approach then allowed us to go through the exercises. For this session that you're about to see, this was completed after her intensive. She had done an intensive initially where we did a mix of sessions at the office and at home. And then this was a couple months later, she had been traveling and we did an online session to check in. And it was great because then with online, she easily transitioned and was able to keep up with those exercises. With post-stroke, they might do the full 1 month intensive, but then you also might want to schedule periodic check-ins. And so we'll go through to the next video, but for this next one, it shows a nice model where post-stroke, you might need to do more gestures, you might need to model the exercises, and that's true for core LSVT loud principles where you want to focus on loudness and you want to show it. Do what I do and really have them copy your behaviors because that reduces a lot of cognitive load so they can focus on the task at hand. And you can go ahead and play this one.
Okay, so first up, we're gonna do an ah. I want you just to watch me for this one. So you're gonna go ah. I want to hear your loud voice with it. Go ahead.
Okay. Wow.
Nice, you are back. That was an excellent loud voice. We're gonna work out with our loud voice today, but it sounded good.
Okay.
All right.
Perfect. And so in that video, that shows her maintenance of that loud voice. And within LSVT Loud, there are a lot of principles that post-stroke really help with that rehabilitation to maintain it long term. It's intensive, it's high effort. And so you as the coach want to really keep your energy levels up so that the client can feed off of that. For individuals post-stroke, they might experience fatigue, and so you want to consider the timing of the day that you're doing the session to make sure it's optimal for them. And also, your energy, you being that cheerleader, is really going to drive better results. But within that, you're training the healthy vocal loudness. You want to consider a complexity of tasks that will help with maintenance. You're constantly doing repetition, using that loud voice, providing those models, and making sure that the tasks are salient. You'll see later on when we do her phrases, she was speaking in English and Amharic, so we wanted to work on the materials in both languages so that it was really salient for her. And you're very specific with the exercises and with your cues, and constantly providing that calibration. You might need to modify your calibration cues for someone post-stroke, where you'll find the scale that works for them. Sometimes I'll ask clients on a scale of 1 to 10 how much effort they're using for that loud voice. Other times I might use gestures where I'll show my hands of a little loud voice, a medium loud voice, a big loud voice, or a huge loud voice. And they can start to figure out what the effort level is that they're using to get that nice, healthy quality and good vocal loudness. And so we can go ahead and move on to the next video, which actually, Cynthia, I think we can skip this one. This is a low ah, and go to the next one, which is her phrases.
All right, so we did a set in English. We're going to do them in Amharic now, too.
Okay.
All right, so look at the piece of paper if you need them. But we're going to start with Ishi Turuno.
Ishi Turuno.
Nice. That was loud. That was sounding really good. When you're loud, it sounds so clear. Everybody's going to be able to hear you and know what you're saying.
Okay.
Try it again. Next one, we're going to say Buna Tatalo.
Buna Tatalo.
Nice. That was nice and clear. You have beautiful Amharic. I'm going to butcher it over here. Next one, you're going to do Wuatatalo.
Wuatatalo.
Yes. Nice loud voice. All right, this one's my favorite one. You ready? Anunkasakasalo.
Anunkasakasalo.
Yes. Nice job. All right, this one is tough for me, but I think you can do it. It's Enid.
Enid.
Good. That one sounded much better coming from you. All right, here we go. Up next is Course Anubla.
Course Anubla.
Very nice. And then Mesa Anubla.
Mesa Anubla.
You're sounding nice and loud. That is a good loud voice.
Okay.
All right, here we go. Arfalo.
Arfalo.
Perfect. Nice loud voice on that, Maza. All right, here's another good one. Shintibit Hedalo.
Shintibit Hedalo.
Good. Nice loud voice, Maza. All right, and then this one's a little bit tough. Terragina Lesh. Yes. How did my Amharic sound?
It is good.
Oh, it's good. It's getting better. That's good.
So for her, within that, we started out where she was copying my models, and then in Amharic, I had it written out with cues for me to be able to model, and her family worked with me on pronunciation. But then we also would then do her phrases with added cognitive load, where she would have it written down on a piece of paper in front of her, working on it in English, and then would do dual tasking of switching with that attention demand of reading the phrase in English and then reading it in Amharic. And that is a way to then increase that complexity, help with generalization, and you're also working on those cognitive communication skills and overall executive function to up the complexity of the task. I think that we can skip this video though and go to the last one, which is her working on conversation. And we'll use that one to wrap up for today. For this video, you'll notice that I have visual cues at the beginning to start with the conversation. And there is a communicative breakdown, which then we use the loudness to help improve that communication. And this will be our last video for today.
How was the trip back to the US? Did you get to fly in recently?
I was a trip to the US.
Good.
It is long from
It is long. How many hours is it to get back here?
What? I was a trip to the US. It's long. How many hours was the flight? It is 13.
13 hours?
Yeah.
Oh man. Was it direct?
Yeah, sometimes to DC.
And sometimes you have to do the stops?
What?
Was it direct or did you have to stop?
Was it direct or do you have to stop? Yeah, I saw on DC. DC.
So you had to stop a little bit?
Was it static or do you have soap? Yeah, I did soap on DC.
Over where?
DC.
Digi?
DC.
Oh, in DC. There we go.
Right.
Got it.
Okay.
So use your loud voice again. You're going to say, I had to stop in DC.
DC.
There you go. That was clearer. With that loud voice. That was pretty good. So you went from Africa to DC and then kept going?
No, I was it's this was my daughter. I went. It's I was with
Yeah, that's pretty good. So you were able to fly over, spend 8 days with her, and get a little bit of a trip in before you kept going west.
Yeah, I was with my daughter. It's this.
Yeah. Did you have a good visit over those 8 days?
Yeah, it's good. No, it's cold.
It was
Very
cold.
Perfect. So within that video, you can see how far that she has come, and this is where the generalization and maintenance piece comes. During those exercises, you want to be doing that carryover practice, really allowing the client to internalize those strategies, and also doing family and caregiver training so that they can do that support. This was a check-in session, and so you can see that she was able to maintain those results for months. And as she was speaking, that she went from having very low speech intelligibility, where she couldn't participate in conversation, that now she was able to maintain the results from her LSVT LOUD treatment, in addition to the cognitive communication work that we did. And online, in her first online session, was able to navigate those demands. And within post-stroke, also needed to do those strategies of sometimes having visual, sometimes having that connection where she could see my face. But overall, she had a really nice result from this program. And so that would be a candidate where you might consider using LSVT LOUD post-stroke. And so now I'm going to pass it back over to Cynthia so that she can give a preview of some slides from Christy.
Thank you so much, Brianna. It was great to see it sort of come to life in a full case study, and to get to see those wonderful videos, and your Amharic is beautiful. So I congratulate you on that. Again, this part of the presentation was going to be Christy's. She has no voice, so I'm gonna highlight it at a high level. We'll get her back and have her share her full depth and breadth of knowledge. But now let's just summarize and expand just a bit further beyond stroke to TBI and other acquired brain injuries. And I think the key thing to keep in mind is utilizing procedural memory. And one of the beautiful things about LSVT is how it speaks directly to one's procedural knowledge, possibly bypassing the declarative knowledge or that learning on purpose. Watch me and do what I do is a hallmark of how we deliver LSVT LOUD. And you saw Brianna do those very nice models of the behavior with her client. And so that goes to the knowledge that one doesn't need to purposely think about it. Our clients then are oftentimes able to absorb this information. They know what to do, they know how to do it, even if they don't necessarily know that they're learning it. And they don't need to think about the process or why or how it comes about. And those cues for loud become very triggering. In fact, one of the sayings we teach in our courses is for our clients, we say, you brush your teeth, you do your ahs. But that loudness becomes that much a part of their daily practice and their daily speaking. So watch me again, do what I do. We say it's the most powerful teaching technique you can learn with LSVT LOUD. And it's not uncommon for therapists to tell us, even if I'm not doing LSVT LOUD or treating other clients, modeling and the simplicity of my instructions has changed how I do my speech treatment. So minimize those explanations, minimize that cognitive load. We say show, don't tell. Model, allow the client's system to learn, as well as we modulate our modeling. Early on, we may be very much over exaggerating, putting emphasis on certain elements of our model, even though our cue is loudness and that good, healthy vocal loudness. And then as treatment progresses, we're often able to scale back some of that modeling as the client internalizes what they need to do. So don't discuss the details. We don't need to overload with words, overload with instructions. Model, reinforce, repeat. Model, reinforce, repeat. We are skill building, not informationally instructing. This is also one of the hardest things for us to do. We get it intellectually, don't talk, model, but it's very hard to do initially, and it takes practice as a clinician to kind of really learn how to pull back on our verbal cognitive overload and allowing that motor model to work when we're focused on treating the motor speech components. It's a process that we're building brick by brick. We're gradually increasing practice, and mastery arises over time. The process does take time, and we're building these daily increments of loudness and vocal stability with that trigger into things such as articulation. I'm sure you could see in the videos when she really put the loudness into those functional phrases, how we also saw that improved clarity of speech and that articulatory precision. And that's the beauty of intensive treatment. We're building these daily increments of loudness. And then as skills improve, we can start to layer on levels of difficulty or levels of distraction to truly ingrain these skills into procedural memory. So the key is we want to be successful but challenged. And we're always pushing for more. If we're sounding good, we like what we hear. Okay, let's see if we can challenge the system. Can they do that with cognitive loads? But we're balancing that with still allowing our clients sufficient success so that they maintain their motivation, they maintain their engagement. And that's a real balancing act. And it's really why it requires the skill and the knowledge of us as speech language pathologists. So these core tenets of LSVT LOUD really in many ways are ideal for people with acquired brain injury. People with TBI in particular need the chance to employ metacognitive strategies. And so the objective of metacognitive skills training is to teach individuals how to self-monitor their performance, identify and self-correct errors, and generate strategies for future use. And again, this is where we will get Christy back and do a full webinar on this because she just has beautiful, extensive knowledge that I'll be excited for her to share with us. But in short, we saw this in the video example with Brianna and her client very nicely. Before she started the session, she reminded her what is going to happen. And she put those kind of tenets of the session there, setting her up with those clear and simple expectations. So posting that schedule of the 6 components of each treatment session, setting time limits for each of those and communicating that, placing a clock where clients can see it and pace themselves, staying in that close communication, what's happening next, why, and what comes next, and being simple and clear with the home exercise program. And certainly, and Brianna talked about this, engaging family and the support network as needed. We provide lots of positive reinforcement, and Brianna did a beautiful job with that. We also have our carryover exercises that start from day one so that they're not just getting positive reinforcement for us, but they immediately have to walk out the door, even if it's a single word, hello, to someone outside of the room, so they start to get that positive reinforcement from people in their environment. And repetition, repetition, repetition. It's key. How many repetitions to a synapse? Data show it takes 400 repetitions to create a synapse while working. However, 10 to 12 if playing. And so hence saliency. We have to make the treatment personalized and motivating. And the Amharic phrases, you saw Maz's face light up, that was meaningful. Repetition never means it's boring or easy, but it's essential to drive neuroplasticity. And we historically quit too soon. We don't do enough repetitions to reinforce to the point of neuroplasticity, or we abandon treatment techniques too soon before we've allowed enough repetition for effectual change. So don't be afraid of repetition. Progress takes time. There's a physiological and a behavioral trajectory over time. And that's where evidence is beautiful, because you can trust the evidence, trust the process, stick with the exercises, and typically you'll always be rewarded. So what's our target? Well, it's personalized and it's salient, even within the standardized protocol. So maybe it's helping somebody to teach your dog a new trick. Get your point across in communication. Share your stories and fun communication settings. Maybe it's to be able to join a book club and share your knowledge with friends. We can all relate to this. To operate technology, can Siri, Alexa, or Google understand us? How about ordering takeout or the drive-through and actually getting the right order because someone heard and understood you? So those are all just beautiful examples of how we make it salient, meaningful, and engaging. And finally, we set expectations for our clients up front. And Brianna talked about this as well. They know what to expect. They know what the month is going to look like. We get our schedules aligned, and we are very straightforward. This is going to take effort, but you are worth the effort. There's no magic pill or easy button, but the rewards are worth the effort. And so we help make it clear what they're committed to, and when they're ready, we're ready to go for it. So in summary, I hope you've recognized now that voice disorders occur as a component of almost every type of dysarthria, and in particular, secondary to stroke, TBI, and other neural conditions. The principles of LSVT LOUD, therefore, both from voice as well as mode, can be applied to a range of dysarthrias by targeting the voice as a source and also a trigger for cross-system effects. And we can utilize a whole range of strategies to facilitate LSVT LOUD in these complex patients. And some of the cognitive strategies, the metacognitive strategies, setting the system up, using dual presentation of visual and auditory that will help really set them up for success. Okay, a few quick housekeeping, and then we'll move to some questions. Our next webinar is in July, Making LSVT Loud Work in Your Clinical World, and you LSVT certified clinicians will be getting information on that as it comes about. And if you're ready to ask a question, you can type it in the control panel. You can raise your hand. If you have a question that we don't get to, you can always email it to info@lsvtglobal.com. I have one question for sure I want to get to, and Brianna, I'm going to have you take a first pass at this. So the question is, I work in a university clinic and have access to many stroke patients who are 10 plus years post CVA. Do you find that time post onset negatively impacts success, or would you suggest an assessment and trial for any patient that may possibly benefit?
Yes, so at our practice, we also see individuals where they're coming in multiple years post CVA, and it is worthwhile if you are noticing that they have dysarthria, that their speech is lower in loudness, it's not quite as clear, intelligibility and articulation are impacted. I would start with an initial assessment with you, where you really dig into that stimulability and see if they respond to those loudness cues and models. And if they're not stimulable right away, you also can gradually work to increase towards those exercises. So sometimes we'll have clients that they have difficulty copying models or initiating that phonation. And so we'll work on those skills first as part of their therapeutic program. And then as they're ready for the full LSVT Loud intensive, then bring that in. But I wouldn't put a clock on how long somebody can impact. I would say even several years post-stroke, they could still see benefits from this program if they're showing that stimulability.
Thank you. And I would agree 100% with everything you just said. So that's great. We are going to stay on and take a few more of your questions that you have, but I just want to let anybody know that if you do need to log off, you have completed your 1 hour requirements. Again, if you're participating live, the survey should pop up. It'll only take a few moments to complete as you log off. If it does not, there'll be a link to it in the email that you'll receive. So if you do need to leave now, please feel free. You've met your hour requirement. If not, we'll stay on for another 5 or 10 minutes and answer a few more questions. Okay, next question. I work in an acute rehab facility where we generally only have patients for 2 to 3 weeks. Is the 4 weeks of consecutive sessions a requirement? So the full protocol is 4 weeks, but we do have tips for you in that case. And so oftentimes the best thing to do is to see if you're able to coordinate with whoever they're going to once they're discharged from you. So once they leave the acute rehab facility, are they going to either have some home health intervention? Is there somebody in the community that can pick them up? Are they moving on to the outpatient facility? And if you're able to pass them on to the next LSVT Loud therapist who can continue with treatment, it's ideal. Other times, maybe they're with you only 1 to 2 weeks. You can consider a 2-week as a trial treatment. It's sort of like an extended stimulability testing in that case. You would then have the recommendation, you're now being discharged. Perhaps there would be a break in care in that transition process. You would recommend the full protocol of LSVT Loud, and perhaps once they get settled, wherever they are in their environment, then the LSVT Loud clinician can start up, and they would literally be starting from the beginning again. So you would have had a week or 2 of trial treatment, you've demonstrated stimulability, move on, and now get the full 4-week protocol. Okay, Brianna, I will let you take this next one. If you decide to do LSVT Loud with CVA patients or patients with TBI, do they still need ENT or at least medical clearance for voice treatment?
Yes, so often with individuals post CVA or who have experienced TBI, I will request their medical records from the beginning of treatment. And so that could include their discharge summary from the hospital, any rehabilitation notes. And within that, you'll typically see they might have had an ENT evaluation, or you'll also see their feeding evaluation as well. And so you want to have that comprehensive overview. I would say that anytime you do have that dysarthria or you are noticing that there is that difficulty with overall vocal quality, that it is good to get the ENT clearance, make sure that everything is okay, but most likely it will exist already within their comprehensive medical record. So if you can get access to that in the beginning, that'll help you streamline the process. We also sometimes have had individuals where they're coming in post CVA, where they also have vocal fold paralysis. And so having the visual examination can also help so that you know exactly what you're dealing with and if they'll be a candidate for LSVT LOUD or not.
Great, thank you. I see a couple people with hands raised. So Tina Parsons, so I'm not sure if you had a question you want to ask, but I've unmuted your microphone.
Hi, this is Tina. Can you hear me?
Yes, we can.
Okay, I work at Fraser Rehab in Louisville, Kentucky as an inpatient acute rehab professional. And I've been LSVT certified for more than 20 years, and I apply these principles to my patients across all dysarthria types. I'm wondering what we can do as inpatient practitioners that can help prepare our patients for outpatient care.
Absolutely, and that's wonderful because we know, yes, oftentimes inpatient, you do not have the full 16 sessions or the full 1 month, or they're medically not ready, right, to take on the intensive treatment. So I think some of the key things is using oftentimes those cues of loud, the simple do what I do just for those immediate communication of basic needs, doing stimulability testing. If you have the opportunity, again, to do trial treatment when they're there with you, documenting what works, maybe what doesn't work, and then setting them up for that post-discharge referral that allows them perhaps to get settled in their next plan of care and then be able to pick up LSVT LOUD. So we definitely encourage you to utilize it in those situations. Recognizing, again, you may not have the full month, but you can get that trial treatment under their belt and then set them up for the next stage. Brianna, I don't know if you have something else you'd like to add to that.
The only other thing that I would add is a lot of times individuals are going from either inpatient acute or the rehabilitation setting. And then depending on the social worker in that setting and getting those services set up for the next stage, sometimes that can be a little bit confusing for families to navigate. And so if you have referrals, if you know there's LSVT LOUD practitioners in your area that you can start to set them up with so that it's a seamless transition from settings, that can also be something to provide extra support.
Great. Thank you, Tina. Okay, I've got another hand up here. I see Paulette. Paulette Scher. Did you want to ask your question? See if Paulette is still here. Are you still here, Paulette? Okay. I don't see anything from Paulette. How about Lisa Esterly? I see a hand there. Maybe not. All right, I've got one more question here. Oh, Lisa, I see you've unmuted. Okay, Lisa, go ahead. I see you've unmuted, but we can't hear you. Perhaps maybe try typing your question in. While you're doing that, I see one person asking, how do I report this class for the CEU credit? The survey is the key. So take the survey information. That will allow us to collect what we need for CE reporting. And again, that CE reporting will occur at the end of the year, but you have credit for it happening now. And then your certificate will have everything that you need if you're using it, for example, for states CEUs or something that you need to be able to show that documentation. All right, one last attempt at somebody raising their hand. Joan, I see your hand raised. Would you like to unmute and ask your question? Joan Cathcart. Okay. Tina was the only one successful at getting the microphone to work. All right, will there be future webinars specific to Loud for Life groups? Yes, we definitely have some webinars on demand, and I believe that we will have one later this year talking more about Loud for Life groups. And if you'd like specific direction where to find those on-demand webinars, email us at webinars@lsvtglobal.com and we can direct you exactly where you need to go. Okay, well, we are 10 minutes past the hour. I want to thank you all so much for being with us here tonight. And we hope to see you at our next webinar. Again, if you have any questions that did not get answered, I apologize if it was our system not allowing some of you who had your hands raised. But please email us in. We will answer them. Brianna, thank you so much for your knowledge and sharing your case. Christy, thank you for your knowledge, and we'll pick your brain and get you live on a webinar as soon as you get your voice back. I wish everyone a wonderful evening, and thank you for joining us.